As you all may know, and I am also a member of the BROCA Society, specifically the Vice Chairperson, and today I've been granted with actually the honor of performing the abdominal examination. And the examination of the GIT is fairly a long one, but it can be made quite easy if you follow the right steps and you are confident in what you do. Okay, so we've taken our history from our patient, we've gotten our specific symptoms of the GIT, and now we're moving on to a physical examination, so we can get more information to make an actual clinical diagnosis. Okay, and I also have my patient here, Ms. Notila. And Ms. Notila, it's very good to meet you. And what is your age, Ms. Notila?
32.
Her age is 32. And I also just want you to know that today, I'm a third-year medical student actually, and today I've been asked to do a gastrointestinal examination on you, or an abdominal examination on you. It will involve me actually exposing your abdominal area, but today I won't expose the area for privacy purposes. And it will involve me touching different areas of your body in that area. Is that okay?
Okay.
Thank you very much. It may be a bit painful, but you tell me if you have any pain of that area. Okay. And do you need anyone to be here with you, a chaperone?
No.
You're okay. Okay, perfect. And you're comfortable?
Yes.
Okay. And I just want you to know everything is confidential between us. Is that okay?
Yes.
Okay. Also, that was the professional approach of the patient. And now we're also going to state that the setting of the area, it has very good lighting, and also we have privacy, and there's going to be patient exposure from the xiphosternum down to the pubic symphysis. And also the patient is in a position where she is supine with one pillow under her head for comfort, and also she's going to relax her abdominal muscles by keeping her hands at her sides. And Ms. Notila, I'm also going to ask you to lift your knees as so. You just flex your knees. That will actually help in actually relaxing the abdominal muscles. Perfect. Now we're ready to actually start our examination. Make sure you warm your hands, you wipe your hands, and you've washed your hands, and you wear gloves. And you also ensure that the patient is comfortable, there's confidentiality, and there's consent. Okay, now the patient's, we have to observe the patient's general condition first. The patient, to me, Ms. Notila, actually is conscious, she's cooperative orientated, she doesn't seem to be under any form of respiratory distress, and Ms. Notila is also under no pain as I can visibly see. She is neither obese and she's neither emaciated or too thin, she's in good nutritional condition, and the patient doesn't have any visible abdominal masses. Okay, I would also check the patient's vital signs. As you can see, my equipment here, I have my stethoscope, I have my blood pressure, and the blood pressure cuff will be used to test for your blood pressure is a vital sign. And you also have to test the respiratory rate, with the normal respiratory rate range being 12 to 20 breaths per minute. You would also check the pulse, the rate and the rhythm of the radial pulse in this region, lateral to the flexor radialis carpius tendon, and you check for rate and rhythm, normally 60 to 100. Thereafter, you'll check the temperature of the skin, you'll check for skin turgor, and you also check for capillary refill when you actually press down the nails and check if the perfusion is rapid. And skin turgor to test for hydration, as I said before. Okay, the vital signs are done. So, the hands will be checked for the temperature first, and the temperature is normal, and the hands are not too warm, and they're not clammy or sweaty. They're in normal condition. I'd also check the fingers for any lesions. And also, I would check the nails now for any leukonychia, and there's no leukonychia, which occurs in hypoalbuminemia and also liver cirrhosis. And now there is no cholionychia, which usually occurs in iron deficiency anemia, often caused by cancer of the bowel. Also, there's no clubbing of the patient's fingers. I would look at the patient's nail from a lateral or horizontal position, and there is an obtuse angle between the nail plate and the nail bed, which is normal. Also, I'll check for fluctuation on either sides of the nail plate and the nail bed, and the patient, it doesn't seem that the patient has clubbing based on this test. Ms. Notila, may you also do this with your nails for me? When looking at the nails, Shamrock's window is present between both nails, and that shows that the patient does not have clubbing bilaterally on her hands. Okay, thereafter, clubbing also occurs in liver cirrhosis, ulcerative colitis, and Crohn's disease, the latter two being the inflammatory bowel diseases. Thereafter, you're going to check for palmaerythema, and the patient does not have that because it's a vasodilation on the thenar eminence of the hands, which shows liver dysfunction. The patient also doesn't have exanthemata of the wrists, and that is lipid deposition in the tendons. And now I'm going to ask you, Ms. Notile, please may you do this with your hands. The patient does not have a hepatic flap, which shows chronic liver failure. Okay. Thereafter, the patient's skin is also of normal temperature, and also the patient's skin does not appear yellow, which usually occurs in jaundice. Okay, checking the patient's forehead. The forehead appears normal, and there's no temporal muscle wasting of the forehead of the patient, and also there's no syndromic features of the patient, such as SLE or Down syndrome. Thereafter, the patient's skin color is also normal. It doesn't appear yellow as in jaundice. Ms. Notile, this may be a bit uncomfortable, but please look up for me. The patient's conjunctiva are red, so she does not have anemia based on the sign, and no pallor. And may you look down. The patient's sclera are not yellow, so therefore she does not have jaundice or yellowing of the sclera. I'll also check the patient if she has for her dryness or hydration of her lips. They are plump and they are wet and moist, and the patient's hydration is good. May I ask you to open your mouth, Stratila? Okay, eyes with your tongue forward. Perfect. And I'm going to look at the buccal mucosa, and I'm also going to look at the tongue itself. So there's no central cyanosis or pallor, and good hydration of the mucosa of the mouth. The teeth are okay, and also there's no gingivitis. And please just lower your tongue for me. We would use a tongue depressor normally. And also you check for tonsillitis, pharyngitis, gingivitis, and tooth decay. Okay, and there seems to be good hydration and no central cyanosis. Thank you, Ms. Notile. Thereafter, I'm going to move on to the legs for the general examination. Thank you. Sorry about that, Ms. Notile. You'll check for tenderness of bilaterally, and you also check for the test for pedal edema. So you'll remove the patient's socks, and you'll place your finger on the tibia of the patient, press down, and you should see pitting edema in the case of pitting edema, which is a pathology, but this patient does not have that sign bilaterally. Okay, thereafter, I would ask the patient to remove her socks as well to check for clubbing and cyanosis of the toenails, and also check under the foot always, because you may miss out a significant pathology. Thank you. An important part to examine in the general examination prior to the GIT examination proper is actual examination of the supraclavicular lymph node, especially the left, which is the Virchow's node. And if enlarged, is called Trozier's sign, which often is suspected of a malignancy from the stomach, like a gastric cancer. Because remember that the lymphatic or the thoracic duct, it drains bilateral parts of the abdomen and the left thorax. So a large amount of lymph flow is reaching this area in the Virchow's node. So any abnormality must be noted. So Ms. Notile, may you sit up for me and put your legs over that side. The examination of the Virchow's node is as follows. Ms. Notile, please relax your head on the left, and you'll expose the supraclavicular lymph node on the left and palpate that lymph node specifically for Trozier's sign. And there's no enlargement and no pathology here. Okay, Ms. Notile. Okay. Now we're actually moving on to the juicy parts, because we have to see actual problems with the organs of the abdomen. So first of all, the patient, because there's actually no proper privacy, it's theoretical, so we're just going to assume that the patient's abdomen is exposed. We're going to check the abdomen at the foot of the bed for any distension of the abdomen, any distended veins, any visible peristalsis, and any actual and visible abdominal masses that you can see with your eyes. And if the abdominal moves normally with respiration, which actually I can see that it does. Okay. Upon palpation of the abdomen, it's important that the technique is correct. There's light palpation and there's deep palpation with the patient breathing. With palpation, you must make sure that your fingers move with the metacarpophalangeal joints as follows. And also you have to use the lateral most part of the forefinger, because it's the most sensitive part. So, you're going to do light palpation first, but you're going to ask the patient, such as in this situation, Ms. Notile, do you have any pain anywhere around here that you want to tell me about?
No, no pain.
Very good. So you're going to ask her if she has pain first, and then you're going to examine. Continuously looking at her eyes while you examine in all the 9 regions of the abdomen to see if there's any tenderness. And in light palpation, you're going to check for the following: guarding, rigidity, and rebound tenderness. Those 3 things, and we're going to do it as follows. In the 9 regions of the stomach specifically, you must, in light palpation, continuously look at the patient's eyes as I told you. So, flexing at the metacarpophalangeal joints, let's start in the right hypochondriac region, which contains the liver and gallbladder. We're going to move to the epigastric region, which is the pancreas, stomach, and common bile duct. Then the left hypochondriac region, which we're going to check for the stomach and spleen. Then the right lumbar region, we're going to check for the kidneys, the right kidney. The periumbilical region, which is the small intestine, we're going to check for the left lumbar region, which is the left kidney. And we're going to check for the right iliac fossa, which contains the ovaries, and the suprapubic region containing the bladder, and also the left iliac fossa containing the left ovary. And I've noted no pathology, no guarding, rigidity, and rebound tenderness, and the patient experienced no pain. On deeper palpation, you're going to palpate all 9 areas, but you're going to palpate specifically for masses and our organ enlargement, which is important. So, deeper palpation, and you're going to press down harder, noting any pain again, and I don't have any masses which are occurring in the regions here, as you can see. And while we're on the topic of abdominal masses, as soon as you locate an abdominal mass, you have to state the following about that abdominal mass. You have to say whether it's in the abdomen or not, the site, the specific region where it's in, the size, the shape, the surface, the consistency, the edge, whether it moves up or down with respiration, whether it is tender, inflamed, and hot, and also if the mass has an edge and its consistency, and whether it's expansile, reducible, or compressible. You also have to percuss specifically that mass to see if it's dull or resonant, and you even have to use your stethoscope to see if there's any bowel sounds or bruits within that abdominal mass. Perfect. But that's abdominal masses on its own, which I chose to include here since it's being in context. Thereafter, continuing with the deep palpation, as I said. The patient experienced no pain and I saw no masses, and also we're going to check for organ enlargement now. So, first of all, the liver enlargement. We're going to check with deep palpation and we're going to use the lateral side of our forefinger. So, Ms. Natila, may you breathe in and out for me. So just when you breathe in, hold your breath, and I'm going to tell you when to breathe out. Okay, so try now, and breathe out. So as you can see, every time she breathes in, you push your finger in and she breathes out. So you're trying to actually feel the lower edge of the liver. One more time. And breathe out, please. Perfect. So the liver is not palpable, and pathologically it is. And we have to also percuss it from the transumbilical plane, and it should appear resonant, as you can hear, and it should appear dull as you appear to the costal, as you appear over the costal margin. And thereafter you have to also percuss downwards from the midclavicular line to see the normal liver span, which is from the 5th intercostal space and 13 centimeters downwards. So you have to, which is resonant, normal resonance, and then when you actually get to the liver itself, you actually get to dull, which is the normal liver span. The features of hepatic enlargement or hepatomegaly are as follows, if you ever do notice a liver enlargement. Hepatomegaly is, the liver is enlarged inferiorly. It moves inferiorly with respiration. The liver, you cannot get above it because the rib cage is above. It's dull to percussion and it's not blottable. Those are the 5 signs that you look for, or rather not signs actually, let's just call it characteristics of a hepatomegaly. Okay, and on the status of a pathological liver, on the topic of a pathological liver rather, we're going to actually just mention the signs of acute and chronic liver disease and liver failure. You should actually mention this in the general exam, but I chose to include it here because hepatomegaly and liver pathology produce the symptoms and signs of liver disease and liver failure. So, going forward with this. Acute and chronic liver disease present with the following: clubbing, leukonychia, palmaerythema, spider nevi, gynecomastia, jaundice. You're also going to have testicular or gonadal atrophy, and going back to the axillary alopecia. Liver failure is defined by 4 things: constructional apraxia, hepatic encephalopathy, a hepatic or liver flap, and methyl mercaptans, or also called fetor hepaticus. Now, important things to notice about those actual definitions or signs. You must note that the spider nevi are only formed on the upper part of the body because it follows the superior vena cava distribution, as they are telangiectasis with a central large arteriole and many large blood vessels flowing out from them. Also note that the hepatic encephalopathy or hepatic flap is brief, and it's elicited when you dorsiflex and extend dorsiflex the wrist and extend the fingers. Notice those important things. And liver failure with hepatic encephalopathy, there are high levels of systemic circulating ammonia which disturbs CNS function. And methyl mercaptans, the liver, because it's in failure, it cannot metabolize methionine, and thereafter you get a musty and sweet odor of the breath, which is distinguished. So thereafter we're going to see the patient's spleen, if it's enlarged or not. So we're going to start palpation from the patient's right iliac fossa, and you're also going to compress the patient's ribs or chest wall a bit. So I'm going to ask you, Mr. Natila, please may you breathe in and out again. So breathe in, push in, and breathe out. Again, and breathe out. And one more time. And breathe out, please. And just the last time. Push in and breathe out, please. So I'm not noticing an enlarged spleen, which usually occurs when it's 3 times the size, and any enlarged spleen of any size is pathological. If you can't feel the spleen, do another test. So turn the patient towards you. So Mr. Natila, please turn towards me. You still compress the ribs and you do the same test. So please breathe in for me. Breathe out. And breathe in again. Breathe out. And breathe in again and breathe out. And breathe out, please. Okay. So the spleen is not enlarged in this case. And after we have to percuss for the spleen. So may you just lie down again straight, Mr. Natila, and we might flatten them. Now we percuss from the right iliac fossa to the splenic area, because on a splenic enlargement you have enlargement towards the right iliac fossa. So it's going to be normally resonant. It's going to be normally resonant physiologically, and it's going to be dull when you actually reach the actual lower left costal margin. And now when you percuss, you have to percuss from above as well, because the spleen occupies the areas 9 to 11 in the ribs. Okay, and you're going to experience dullness in those areas because the spleen is an intraperitoneal structure. Okay, thereafter we've percussed it and we palpated it, and we also have to mention the actual signs of a spleen which is enlarged. And it's like the liver, except that it has one difference. So we mentioned, like the liver, that it's dull on percussion, you cannot blot it, and you can't get above it because it's in the rib cage. But you must note that it enlarges inferiorly towards the right iliac fossa, and also it has a notch. The splenic notch is very important. For both the spleen and the liver, one should also use your stethoscope as so, and you should use the diaphragm to see if there's any bruise, any bowel sounds, or any rubs in the regions of the spleen or the liver. Okay, then finally for enlargement we need to focus on the kidneys. So the kidneys are located in the lumbar regions or the flanks. So Mr. Natila, I'm just going to put my hand under. So you put one hand under and you put one hand on top of the lumbar region. And it's called bimanual palpation for the specific reason, because you're using 2 hands. So you flex your lower hand, and you try to catch the kidneys and try to blot them. That's what it means. And I can't do that in this case. You make actually an attempt while the patient breathes to catch the kidneys in between your hands, and you do the same on the other side. The enlargement of a kidney is actually different from the liver and the spleen in the following ways. The kidney enlargement is actually resonant to percussion. You can get above it. It's rounded. The surface of the kidney is rounded, as you know, normal anatomy. And also, the kidney also extends inferiorly with inspiration or respiration. Alright, now we've seen our three most important organs in this examination, and they are not enlarged and they are normal. Now, to move on to the final stage, which we're going to test for ascites. And ascites is very important because it presents in very important pathologies, like whether it be a nephrotic syndrome, whether it be liver disease, or whether it even be heart failure. Alright, so let's continue. So to test for ascites, we're going to do three tests specifically. We're going to check fullness of the flanks and if the patient were to be exposed, and we're also going to check for shifting dullness. So you start from an area of resonance, you move, you keep moving, and you mark where it becomes dull. So you mark it, and then you ask the patient to turn over. So Ms. Matilda, turn the other side, please. Yes, you turn the other side. And you keep, you actually wait for a little while, and then you're going to actually percuss again. And if the percussion note is the same, such as dullness in this area, you shouldn't have ascites. If the dull note changes caused by the moving fluid, then that should signify ascites. Okay, just relax in normal position again, Ms. Matilda. So there was no full flanks, there was no shifting dullness, and now we're going to test for a fluid throw. So I'm going to test here, and I'm going to flick while observing the abdominal wall exposed. And you're going, please just put your hand like this in the middle, Matilda. Perfect. Then you flick again. And that would test for a fluid throw, which would also signify ascites. Those three things. And the last one you can check for is a succussion splash, but does not test for ascites, it tests for pyloric stenosis. So you just take the side of the patient and you'll shake the side of the patient as so. And you listen for fluid in a hollow viscus. Perfect. Thereafter, the examination would be completed, and the examination of all of those abdominal is completed, but you always have to end off any examination, any very vital examination, with auscultation. And remember, you're dealing with the bowel, so you're going to have to check for bowel sounds first. So you check with the diaphragm and you listen for normal bowel sounds, which appear relatively frequently inside the small bowel. You place it over different areas of the periumbilical area, and they should come, except two conditions would present with no bowel sounds, such as paralytic ileus or even peritonitis. You won't get your bowel sounds. Bowel sounds change to high tinkling in conditions like bowel obstruction, where you get high tinkling bowel sounds, you get visible peristalsis, and you get a distended abdomen, of course, because of the obstruction. And for any abdominal obstruction or any abdominal distension, you're going to look for your various Fs, whether it be fat, fluid, fetus, fibroids, or even full bladder even. That's very common. Okay, and you're going to be checking, again, using your stethoscope for any form of rubs, any bowel sounds, as I said, and any bowel sounds in any masses. And ending off, you have to check using your stethoscope. You have to check 2 to 3 centimeters above the umbilicus, and laterally as well for any bruise of renal artery stenosis, and any sounds emanating from an abdominal aortic aneurysm. And also you're going to check for any rubs as well, which are pathological. Then thereafter, you complete the examination, and I'm summarizing that there are no pathologies present of the gastrointestinal system, and the patient can reclothe herself, and I'm going to thank Ms. Natila for being so cooperative in this examination. Thank you very much, and this has been Ishq Pramchand on BROCA, Better Speakers, Better Doctors.